Hello viewers. Hello. I am Dr. Puspen Dasgupta. This is my channel. Welcome to my channel. If you are watching this for the first time, then I make videos about ENT, how to prepare for MRCS ENT, how to prepare for occupational English test, which is an English language proficiency test, and also travel videos documenting my travel experience in the United Kingdom. I'll leave a link to all those videos in the description below. As promised in yesterday's video, I will be uploading videos every day of the week, and each day will follow a particular theme. The theme for Monday was MS ENT, and the theme for Tuesday is surprise, surprise, MBBS ENT. Now, before you tune out, I must tell you that the syllabus for ENT remains the same irrespective of the exam you are taking, whether it is MBBS exam or MS exam or even membership of Royal College of Surgeons exam. The syllabus remains the same, the assessment changes, and the expectations from the examinees also changes. In the MBBS exam, with the onset of new regulations introduced by the National Medical Council, the question paper for theory exam is of 100 marks and it carries a section called Explain Why. Typically, it contains 5 questions carrying 4 marks each. It may differ from one university to another, but Explain Why is a question that you can expect to encounter in your MBBS exam. And it is also something which is worth understanding if you have any interest in ENT, whether it be as a postgraduate trainee or someone who is preparing for MRCS ENT or both. So without further ado, let's get into the meat of discussion. What is meant by Explain Why? Explain Why questions, typically in my experience, are the questions where the MBBS students struggle the most. Why is this the case? Because in my opinion, most people are very happy to learn about new things. Understanding new things is sometimes a challenge. So if you understand what you are learning, then it becomes slightly easier. For example, look at this question. Prussak space is prone to formation of young cholesteatoma. Now there is so much information here. If you are not familiar with medical jargon, then you don't know what is cholesteatoma. You don't know what is Prussak space. If you don't know these things, then you cannot answer this question. So first of all, you have to know what is cholesteatoma. Cholesteatoma is a severe infection of the ear, which in simple terms is skin in the wrong place. Now you have to know where in the ear skin is supposed to be there and where in the ear skin is not supposed to be there. So the question itself suggests that Prussak space is a space where skin is not supposed to be there. So what is Prussak space? Prussak space is a part in the upper part of the tympanic membrane. It is a space, so of course it will have boundaries. What are the boundaries of Prussak space? Prussak space has 4 boundaries. The lateral boundary of Prussak space, or the outer boundary of Prussak space, is pars flaccida. The medial boundary of Prussak space is neck of malleus. The inferior boundary of Prussak space is the lateral process of malleus, and the superior boundary of Prussak space is the lateral malleal fold. You have to remember the boundaries of Prussak space. And while answering the question, it is a good idea to draw the diagram. Now you know what is cholesteatoma and you also know what is Prussak space. Why is then Prussak space prone to formation of young cholesteatoma? Now this is a question that was asked in one of the internal assessment exams in one of the colleges. So I've just lifted this question directly from that question paper. So don't blame me for any grammatical or question framing related errors. This is just a question that if you encounter, how do you approach it? So whenever you get a question in your exam, please don't find mistakes in the question. Try to find the answer. So how do you answer this question? First, you write down the definition of cholesteatoma. Then you draw a diagram of Prussak space, mention its boundaries, and then you try to address the main question. Why is it prone to formation of young cholesteatoma? It is because, as per one theory, Prussak space develops due to resolution of the mesenchyme. Now, it is typically seen that by about 4 years of age, Prussak space develops normally in the temporal bone. In cases where during the early childhood, the patient has otitis media with effusion, then the normal aeration routes are not typically formed, and there is development of negative pressure. Now, this negative pressure leads to incorrect development of the Prussak space. Now, because of this negative pressure in the Prussak space, there is a propensity of formation of retraction pocket, which leads to formation of cholesteatoma. So very simple. The most common theory of cholesteatoma formation is the retraction pocket theory. And retraction pockets are most prone to develop in the Prussak space as seen in the development of the ear. Typically in the first 10 years of life, if the patient has bouts of otitis media with effusion. So this is why Prussak space is more prone to formation of young cholesteatoma. So just to recap, Prussak space is prone to development of negative pressure in children who have frequent episodes of otitis media with effusion. This negative pressure leads to formation of retraction pocket, and this retraction pocket in the Prussak space leads to the formation of cholesteatoma. Again, this is just a hypothesis, and this is a good explanation for the question, why is Prussak space prone to formation of young cholesteatoma? If you have any doubts about this explanation, please feel free to comment in the comment section below. I'll be happy to get back to you. The next question that I would like to answer today is explain why in maxillary antral CA, CA here means cancer, explain why in maxillary antral CA, endoscopic biopsy is preferred to sublabial route of entry into antral. This is a fairly simple answer. Now, the key thing to understand is when you are answering an explain why question, you have to look for logic. So here there is a patient who probably has carcinoma of the maxillary antrum. Maxillary antrum is a space in the cheek. So you can approach it through the nose endoscopically, or you can approach under the upper lip, which is the sublabial approach. Now, if you approach it sublabially, what happens is you are creating a new pathway which can allow spread of the cancerous tissue. There is no natural opening in the sublabial aspect. There is a natural opening of the maxillary antrum in the endoscopic route, which is the maxillary ostium. So you're not making a new opening. So it is always better to not create a new path which can be a potential route for spread of the cancerous tissue. So you prefer the endoscopic route because then you are not creating a new route or an iatrogenic route for spread of the cancer. So very simple, endoscopic biopsy is preferred to sublabial route of entry into antrum to prevent the creation of a new pathway for spread of the malignant tissue. Again, if you have any doubts about this explanation, please feel free to comment in the comment section below. The next question for today is explain why topical steroids are not given in post-surgery of AC polyp. Again, please don't blame me for grammatical errors. I have just lifted these questions from a question paper. So again, if there are errors related to question framing, then don't blame me. Let's look at the answer. So basically what the examiner wants to find out is why are topical steroids not given following surgery of AC polyp? What is AC polyp? Antroguanal polyp. So here we have to understand what is the role of steroids and what is the pathology in AC polyp. So steroids, as we know, they are immunosuppressants. They play a role in modulating the immune response of the body. Now, is AC polyp an immune-related disorder? Is it related to immunity? Is it related to allergy? Is it related to hypersensitivity? None of that. Now, till date, we don't know for certain why AC polyp develops or what is the exact mechanism. But we do have some facts on our side, facts that are verifiable. So under microscopic examination, it has been observed that AC polyp interstitium does not contain eosinophils. Eosinophils are typically seen in allergic disorders. Allergic disorders are disorders which are hypersensitivity reactions, basically an aggravated immune response. So AC polyp does not have eosinophils on microscopic examination. The typical signs of allergic rhinitis are not encountered in a patient suffering from AC polyp. Also, there are two hypotheses for development of AC polyp. One is the faulty maxillary ostium theory, that the maxillary ostium is faulty in cases of AC polyp, or there is a presence of an accessory ostium. So this is one theory of development of antroguanal polyp. there is another theory called the Bernoulli's theorem theory. Bernoulli's theorem states that in the stenotic areas of the nasal cavity, due to negative pressure, there is accumulation of edematous fluid in the submucosa. Bernoulli's theorem states that in stenotic areas of the nasal cavity, due to negative pressure, there is accumulation of edematous fluid in the submucosa. So again, both these theories say nothing about the immune response of the body. And of course, on microscopic examination also, you don't see any evidence of any kind of immune response. So there is no role of topical steroids, or for that matter, any kind of steroids in treatment of AC polyp before surgery and even after surgery. So the accepted mode of treatment in antroconal polyp is surgical excision, preferably through the endoscopic route. Again, if you have any doubts about this explanation, if you think I'm saying wrong stuff, if you want to correct me, feel free to comment in the comment section below, and I'll be happy to learn from you. Please don't take my words as gospel. I am answering to the best of my knowledge, but as a humble man, I have to accept that maybe sometimes I am also wrong. But this is the best answer I could find, and I hope this will help you in your exam. The next question that I want to answer here is, explain why Eagle syndrome causes cervical pain and pain to open mouth. Again, please don't blame me for grammatical errors. If you want to answer this question, you have to first know what is Eagle syndrome. Eagle syndrome is a syndrome which is associated with elongated styloid process. So there is a bone in the temporal, there's a process, there's an elongated part of the temporal bone called the styloid process. This styloid process, when it becomes too long or longer than normal, elongated styloid process, it starts impinging on various structures in the neck and it causes pain. So cervical pain in Eagle syndrome, also known as stylalgia. Cervical pain in Eagle syndrome is due to compression of the nerve roots lying close to the cervical spine, and painful mouth opening in Eagle syndrome is due to the styloid process impinging on the trigeminal nerve. Trigeminal nerve supplies the muscles of mastication, and as you know, the muscles of mastication are largely responsible for opening and closing of the mouth. Now, in Eagle syndrome, there is compression of the trigeminal nerve, the nerve plexus surrounding the carotid artery, and there is the compression of the glossopharyngeal nerve. So these nerves are typically compressed in Eagle syndrome. Glossopharyngeal, trigeminal, nerve plexus around the carotid artery. Okay, so this is a possible explanation of why there is cervical pain and painful mouth opening in Eagle syndrome. Again, if you have any questions, if you want to add to this answer, please feel free to comment in the comment section below. The next question that I want to answer today is, explain why stapedial reflex is absent in late stage of otosclerosis. Now again, we have to understand what is stapedial reflex, what is otosclerosis. Otosclerosis is a disease where there is typically bilateral conductive hearing loss due to faulty bone formation, especially associated with the ear ossicles. Typically, otosclerosis starts at the footplate of stapes, at the fistula antifenestrum. And this foci of faulty bone, or spongy bone, this can move upwards towards the neck of the stapes where the stapedial tendon is attached. Stapedial reflex is when there is loud sound, the stapedial muscle contracts, and it is a sort of protective reflex. It protects the inner ear from loud sound. So the stapedial reflex is contraction of the stapedius tendon, which is attached to the neck of the stapes in response to a loud sound. But if this faulty bone or the spongy bone starts growing from the footplate of stapes and reaches all the way to the neck of the stapes and makes the stapedial tendon fixed, it doesn't move, then stapedial reflex is lost. And of course, this is seen in late stage of otosclerosis when the disease has spread from the footplate to the neck of the stapes. So I hope this explanation is also clear enough to you. If you have any doubts, please feel free to comment in the comment section below. Next question that I want to answer today is, explain why there is loosening of teeth in CA maxilla. Again, CA here means carcinoma, not calcium. So why is there loosening of teeth in maxillary carcinoma? This is because maxillary carcinoma typically spreads, or local spread of maxillary carcinoma is typically in the following direction. It spreads to the ethmoid, it can spread to the orbit, It can spread to anterolaterally to involve the skin. It can spread to inside the nose, and it can also spread inferiorly to involve the alveoli, which is a fancy word for teeth. So if it spreads inferiorly, direct spread of maxillary carcinoma inferiorly, it can manifest as loose teeth. It can also manifest as teeth falling off. It can also manifest as oroantral fistula. So again, I hope this explanation was good enough. If you have any questions regarding this explanation, please feel free to comment in the comment section below. With this, I come to an end. This explanation session comes to an end, and I don't come to an end. Sorry for the mistake, but this explanation session comes to an end. Again, if you want me to answer any questions that you feel is difficult for you, then please feel free to reach out to me, and I'll be happy to answer your questions. And Tuesdays will be dedicated largely to people preparing for ENT exam from the MBBS point of view. And this will be a recurring theme, but all this information is important irrespective of which exam you're taking, whether it is MBBS or MS or even MRCS. So I hope you enjoyed this video. I'll see you in the next one very, very soon. Thank you so much for watching this, and feedback is always welcome. Take care. Bye-bye.